Picture this. It's 2 a.m. You're on call on the medical ward. Suddenly, a 72-year-old man rolls in. He is incredibly breathless, sweating profusely, and literally cannot get enough air to finish a single sentence. You check his vitals right away. Blood pressure is a sky-high 190 over 110. His pulse is racing at 130 beats per minute. You throw your stethoscope on his chest, and you hear it. Crackles, just filling up both of his lungs.
And then you glance up at the monitor. His oxygen saturation is sitting at a terrifying 84%. The tension in the room is absolutely palpable. You can feel it. Every single second counts here.
The nurse turns to you, dead serious, and asks, "Doctor, is this pneumonia, COPD, or pulmonary edema?" You've got maybe minutes to decide. If you recognize acute heart failure and drop that pressure quickly, you might save his life right here, right now. But if you miss the signs, he could literally drown in his own pulmonary edema, spiral into cardiogenic shock, or just go into cardiac arrest. So welcome to our explainer on heart failure, undeniably one of the most common and most dangerous presentations in all of medicine.
Okay, let's dive into this. To make those life or death decisions on the ward, we really need to step back and look at Section 1, the failing pump anatomy.
Now sure, the formal textbook definition involves things like metabolic demands and filling pressures, but honestly, I want you to visualize a physical model instead. Think of the heart purely as a mechanical pump, and it's hooked up to this vast system of pipes that supplies all your organs. Heart failure basically happens when that pump either becomes way too weak to push the fluid forward or way too stiff to fill up properly. The end result? A failing pump and flooded pipes. That fluid has to go somewhere, right? So it just backs up, causing massive, severe congestion.
But here is the great irony of the human body. Heart failure is not just a mechanical pump failure. Fundamentally, it's a neurohormonal disease. You see, when your cardiac output drops, your body completely panics. It thinks, oh no, I'm bleeding out, circulation is failing. So what does it do? It releases this massive surge of hormones, firing up the sympathetic nervous system and the RAS pathway. Now, in the short term, this clamps down your blood vessels and holds onto salt and water to boost pressure. But long term, it is a complete disaster. This overreaction directly causes ventricular remodeling, fibrosis, and just a totally flooded system.
So depending on which side of the pump actually fails, those flooded pipes cause totally different problems. If the left side fails, the back pressure floods the lungs, giving us that terrible dyspnea and those crackles we heard earlier. But if the right side fails, the back pressure floods the systemic veins, so fluid pools in the legs as peripheral edema or in the abdomen as ascites. And crucially, and you got to remember this, right-sided failure is most commonly caused by left-sided failure. Basically, the lungs get so congested that it eventually breaks the right side of the pump too.
Let's look at the two major types of heart failure you're going to see clinically. First up, we've got HFERF. Heart failure with reduced ejection fraction. Think of this as your classic weak ventricle. It's usually been damaged by ischemic heart disease or a previous heart attack, and it's pumping out less than 40% of its volume. On the flip side, we have HFpEF, heart failure with preserved ejection fraction. This ventricle isn't weak at all. Actually, it's stiff. It squeezes perfectly fine at 50% or more, but it just cannot relax to fill with blood unless the pressures are abnormally high. We see this all the time in our elderly, hypertensive, or obese patients. Now, what's really interesting about this next part is how it simplifies your clinical reasoning. Let's move into Section 2, the diagnostic framework.
When you're at the bedside, you literally don't have time to guess. You need to memorize these 5 steps. Step 1. Is the patient congested? Look for breathlessness, listen for crackles, check for automata. Step 2. Is their perfusion adequate? If their hands are cold, blood pressure is low, or they're confused, they are in really deep trouble. Step 3. Is this an acute flash of pulmonary edema or more of a chronic gradual fatigue? Step 4. What actually caused it? And finally, Step 5. What is their ejection fraction phenotype?
Step 4 is really where you have to play detective. Heart failure almost never just happens out of nowhere. It's practically always triggered by something else. So we use the mnemonic CHAMP to find the culprit, and find it fast. Is it acute coronary syndrome, a hypertensive emergency, an arrhythmia like AFib, maybe a mechanical issue like a blown valve, or a pulmonary embolism? Listen, if you just treat the fluid and ignore the CHAMP trigger, I guarantee your patient will bounce right back into the ER.
To confirm what you're suspecting, you've got 4 key investigations. You check a BMP blood test, And here's a clinical pearl for you. BNP is fantastic for ruling heart failure out, but it's not always perfect for ruling it in. You run an ECG to check for ischemia or arrhythmias. You grab a chest x-ray to look for an enlarged heart and all that fluid in the lungs. But the absolute gold standard, the undisputed MVP test here, is the echo. Echocardiography tells you the ejection fraction, the state of the valves, and exactly what kind of failure you're up against.
Okay, so diagnosis is only half the battle, right? Now we actually need to fix the problem. Welcome to Section 3, Acute and Chronic Solutions.
Picture yourself on a fast-paced ward round. Your attending is going to turn to you and ask these exact 4 words. Is the patient wet or dry? And are they warm or cold? Wet just means they're congested. Crackles in the lungs, swollen legs. Dry means no congestion. Warm means they still have good blood flow to their peripheries. Cold means their pump is failing so badly they're literally entering shock. Keep in mind, most acute heart failure patients are going to arrive wet and warm.
So back to that crashing, breathless patient we met at 2 a.m. Here's your acute rescue playbook, LMNOP. You hit them with Lasix, an IV loop diuretic to start clearing that fluid, nitrates to open the vessels and drop the crazy high blood pressure, oxygen if they're hypoxic, and you sit them in an upright position so they don't drown in their own fluids. Now you might notice I skipped the M for morphine. Yeah, while it's in the classic textbook mnemonic, we actually use it much less nowadays. Instead, we heavily favor modern non-invasive ventilation, like CPAP, to physically push the fluid out of the lungs using positive pressure.
All right, once your patient survives the acute crisis, they're going to need long-term protection. For chronic HFrEF, we bring in the Fantastic Four. And guys, this isn't just about making them feel a little better. These 4 specific drug classes actively stop that disastrous neurohormonal remodeling we talked about earlier. We're talking ACE inhibitors, or ARNIs, beta blockers, MRAs, and the newer SGLT2 inhibitors. Together, these 4 pillars drastically reduce mortality and actually keep your patients out of the hospital. But be careful, because the road to recovery is basically a minefield. Number 1 is by far the deadliest mistake: giving IV fluids to a hypotensive heart failure patient without thinking. Their pump is already failing. Adding more fluid will violently worsen their pulmonary edema. Number 2, missing underlying ischemia, assuming it's just a bit of fluid overload when they're actually having a silent heart attack. Always check your precipitants. And remember, treating a stiff heart, HFpEF, requires totally different evidence-based steps than treating a weak heart. So, the crucial point here is your ability to take all of this and synthesize it into immediate action. Let's boil it all down in Section 4, the 10-second survival summary. If you take absolutely nothing else away from this explainer, never forget this foundational mental model. Heart failure is simply the failing pump and the flooded pipes. It's a weak or stiff heart leading to a massive neurohormonal cascade that literally drowns the lungs and swells the legs. Assess the congestion, find the trigger, diurese the fluid acutely, and block those hormones chronically. Because honestly, the stakes could not possibly be higher. If you miss the signs, if you fail to recognize that wet and cold patient, they could drown in their own fluids or go into cardiac arrest before the sun even comes up. The framework is set. You know what to look for. So I'll leave you with this one question. Are you ready for your next 2 a.m. call?